the News Channel 5 network. This is Open Line.
That's our verse, right?
Hello, everyone. Welcome to Open Line. A full house tonight as we discuss one of the most important issues facing our state. Talking about the opioid crisis. What can be done to combat the opioid crisis? The governor has a plan, and we are going to dive into that plan tonight. Happy to have with us Jane Simmons, Policy Director for the Governor's Office. Jamie Simmons, thank you for being with us.
You're welcome.
Also, Monty Burks with the Tennessee Department of Mental Health and Substance Abuse Services, Director of Faith-Based Initiatives. Thank you for being with us.
Thank you, sir.
And a commissioner from the Department of Mental Health and Substance Abuse Services, Marie Williams. Thank you also for being with us.
Thank you.
It's a huge problem. We've talked about it on the show a lot. What is the governor hoping to do? How do we combat this?
So the governor laid out a pretty comprehensive plan back in January, and the key elements of that plan are prevention, thinking about how do we cut down the number of opioids that end up in people's medicine cabinets, how do we think more strategically about educating individuals about the dangers of opioids, even at a young age. Another key piece being treatment. So those who are already addicted, what are we doing in terms of providing access, no wrong door to treatment, which Commissioner will speak to, and then law enforcement. So for those people who are using opioids or trafficking, fentanyl is a common drug that we're seeing trafficked. So what are we doing to make sure law enforcement is equipped with the resources they need in order to combat this issue?
So really three prongs.
Yes.
Prevention, treatment, law enforcement. And we'll have in the second half hour, we're going to have Tony Parker, the Commissioner with the Department of Corrections, Michael Jones from the TBI will be up here answering questions. But the thing I hear over and over is there's just not enough treatment.
Sure.
What can we do?
Absolutely, and that's what was so great about working with the team that's up here, as well as the governor's group and the legislature, who is right now looking at our budget to actually fund more dollars for treatment. When you look at our state, there's about 82,000 people that are prevalence data indicated that need treatment. Of that 82,000, when you break it down into private pay and TennCare and uninsured, where the governor's focusing with his dollars is that uninsured piece, because that's what we're responsible for in the state. And luckily the funds that he is hopefully going to give us through the legislature approving it will really make a huge dent in that. So we're excited about that, but our department's taken it one step further, and that is to work with for-profit entities across the state to take those state funds that the governor's asking for the department and bring in leverage dollars. Now, he did this last year. He said, hey, I'm going to give you dollars to do the pre-arrest diversion programs that help people that have addiction issues. Gave us $15 million, and our communities across the state averaged 25% cash match on top of the 15. So we're really hoping that we'll get to that 12,000 number of uninsured people through the dollars that the governor has allocated.
And Monty Burks, you're Director of Faith-Based Initiatives.
Yes, sir.
Does that mean that churches are going to play a big role here?
Absolutely. And part of the model that we're using, the prevention, treatment, and our law enforcement, we need to have buffers outside of those or after those take place. When a person leaves a treatment program, they need a community-based environment to facilitate that recovery. And part of our behavioral health care model is recovery support. We're working with over 70 counties of faith-based groups, not just churches, but synagogues, mosques, focus groups, you know, any community-based group that wants to work together to help be a buffer for people coming back to their area. 95% of the people who are incarcerated come back to their home area. People that go to our treatment programs come back to their home area. And what a problem was before is they did not have the recovery support mechanisms available to keep them clean, to give them that safe and sober environment.
I mean, when you start talking about the numbers, they're astounding. At least 3 people die each day from an opioid-related drug overdose. So again, when we start looking at the problem, it almost feels overwhelming. I guess first, let's define how big the problem is. The number of prescriptions that are out there, the number of deaths, just how big is this problem?
Yeah, so we know our latest data on yearly prescriptions says we have 7.6 million prescriptions written, and in the context of Tennessee, that's 1 million more than man, woman, and child that we have in our state. So we clearly have an excess of prescriptions that are out there, and what we know is when they're out there, what happens is they sit in medicine cabinets, they get diverted, and we have a real problem around kind of excess opioids in our population. I think we also cite the deaths that we have per year. We say it's 3 a day due to opioid overdose. That's equivalent to if 8 737 planes had crashed in a year. That's the equivalent of what we have with our opioid epidemic. And if that was happening, you'd see the FAA do some real, take some real steps to make sure that wasn't a problem anymore and figure out what's going on. And so I think that's why you see our plans approach it so comprehensively, because we need to pull as many levers as we can. But yeah, it's three overdose deaths a day from opioids.
And how big is this prevention part and the treatment part?
It is huge, and today one of the things that we were so excited about in the federal government, there's legislation that's being promoted that would limit prescriptions to 3 a day, 3 prescriptions a day for people that are needing opioids that don't meet certain criteria. So in the governor's bill, what we love is the fact that he's saying this is serious enough, as Jamie said, that if we were having airplanes crash like this, FAA would be doing something. That's what's so great about this governor, our legislature, and our judiciary. They said, hey, this limit will actually prevent new people from coming into that addiction highway, as I call it, and we talk about it. So that is huge. The other piece of the prevention program that we're doing is a media campaign across the state. So if there's anyone watching tonight, please go to www.tntogether.com. There's incredible information about prevention, education, treatment, and then the things that Commissioner Parker will be talking about with law enforcement, and also Michael Jones about the TBI. There's great information there, but prevention's a huge piece of this. One
of the things the governor's proposing is limit coverage of opioids for TennCare enrollees to an initial 5-day supply as a maximum daily dosage. So he's talking about that limit. And when you hear the stat you gave, that there are 1 million more prescriptions written and there are people in the state, it begs the question, why were so many written in the first place? You know, so we're going to limit it now, but how did it get so out of control in the first place?
Yeah, I mean, without being a doctor, I think even our conversations with doctors have been, this is the way we were trained. When opioids came on the market in the 90s, this was the way we dealt with pain. We even know hospitals, until very recently, were held accountable based on the level of pain of the patients leaving the hospital. So if pain was a bigger issue when that patient left, they could essentially give that feedback, and hospitals were held accountable with that information to say, if they're in pain, that's a problem. And so really just saying, you know, we've got to look at the way we, and part of the plan you'll see is working with doctors as they're coming into training programs, as they go through their own education programs to become future doctors. What are we doing to change the way they handle pain management, to not immediately go to a script for 30 days with no MME limits, but to say, think strategically about the person in front of you and what they need, because 30 days has kind of been the default and often isn't needed.
Sure, and everybody knows people who go in for something and they get a huge bottle of this stuff, and it's just so dangerous.
It is.
It's so addictive.
It is.
And that's why it's hitting all walks of life.
Right.
And I'm sure you see that in the faith-based part of this. Church after church is seeing person you would not expect to be addicted to drugs, and it's hitting their families and just causing enormous damage.
Absolutely, and one of the key pieces to getting to where we are is we haven't talked about it enough. There's a stigma attached to people who suffer from addiction. So when a person knew they needed help, they didn't know who to go to, or they wouldn't go and openly talk about their situation because they felt they'd be judged. And now our faith community is actually stepping up, becoming vocal and visible, providing outreach opportunities and creating access to treatment and to our prevention communities for those people. Right now we work with over 300 different congregations from all different religions and faiths to provide those buffers and to talk openly about what you need. Here is help. Here is access to treatment. Utilizing our Project Lifeline and some of the dollars Commissioner was talking about from the Governor, we're going to expand our Project Lifeline. We have right now 10 people who are in long-term recovery located strategically across the state to provide access to treatment and recovery support services for individuals who need help. With the expansion, we're going to have 10 more, and they look like their community, and they're all in recovery, so they speak a language that a normal practitioner may not necessarily speak, but they'll be able to guide and navigate people to that recovery support.
And what Monty's doing, this is so important, and this is why it was so great when he joined our team. Monty's going out and he's training congregations with other staff members on our team in the community about what is addiction. So not only are we saying you're a recovery congregation, we're training people that are coming in droves when we've gone out, that they're like, hey, what is addiction? How do you treat addiction? And he really gives a great story and brings people around the table to talk about this is not a moral issue. It is not a moral issue. It is a disease like any other disease. So really he strips away that shame and guilt that people feel that are in that cycle of addiction, and it's been a wonderful, wonderful program that he's doing.
And before we go to break, I mean, do you think it's hitting everywhere hard? I mean, the numbers don't lie, but in our rural communities, do you think it's even worse?
When we look at the maps that we look at, first off, we know that the opioid addiction process itself, when you look at where they're at, it's more east, then middle, then west. So it goes that pathway. And then what we're seeing is an uptick in the heroin use, because as people come off pills, people are coming in to traffic heroin, and that really is showing up in urban areas. And absolutely, it's hitting rural, it's hitting everywhere, but if you geographically look at it, more people in east, then you've got the next rung in middle, and then west.
Well, this sets the table for our discussion. We're going to take a break. If you want to call in, there's the number 615-737-PLUS, 615-737-7587. If you're on the line, hold on. We're also streaming live on our Facebook page. I'll read some comments. If you want to comment on the News Channel 5 Facebook page, just put a comment down there, we'll read some. Take a break, be back right after this.